that is being evaluated for increasing shortness of breath and possible early heart failure. Her physical exam reveals an early diastolic decrescendo murmur occurring after an early diastolic opening snap. Which of the following is the ideal therapy for her cardiac disorder? What do you guys think? What would be ideal for her? So she's young. She's coming in, and you have to figure out first, you like, okay, what is this? Where is this located at? What are we thinking? What is most likely causing her shortness of breath and possible early heart failure? What's the underlying etiology? Okay. All right, good. Most of you guys are on the right track, going in the right direction. Keep it going, keep open, keep going. I want the rest of the responses. Knock it out. Get those responses in. All right, good. Okay, the majority of you went with the right answer, which is mitral valve valvotomy or a transcatheter mitral valve replacement. The difference is this is an open procedure. You've got to open the chest and replace the valve. So that would be the ideal therapy, is to do least invasive and do this through it's like doing laparoscopy for surgery. You want to do the most minimal invasive process first. So you can either do it with a balloon portion with a valvotomy or a transcatheter mitral valve replacement. So those are the options that you would want to pick. So least invasive first, always going through that. Yeah, you don't, observation, not a good idea since the patient's already in early heart failure. So that would be bad. We've got to do something, right? So ideal therapy is to go with that. Okay, so this is an explanation for that. It always gives you a little bit more information about what we're dealing with. Obviously, with mitral stenosis, it's usually due to rheumatic heart fever or heart disease, and the mitral valve is the most common valve affected. Remember that medications are not very effective in that area. And so the idea is to do a valvotomy or mitral valve replacement is preferred, because, you know, if we don't want to do it, if we can avoid doing an open surgical procedure, that's a winner. Okay, so remember the valves. The key with this is the pulmonic valve, the second left intercostal space, is going to come down into Erb's point. So once again, we're going to get this pathway. So here's your pulmonic valve, and it's always going to come down to Erb's. The bottom line on this is to remind yourself that Erb's point, that third to fourth intercostal space, that the blood flow is going to come this direction if it's a regurgitant murmur. If it's a stenotic murmur, the blood's going to go out this way, and you'll get a little bit of radiation to the neck, but not as much. Obviously, it's not going to be as much as the carotids, because the carotids will go straight up into the neck, and you're going to get that carotid feel from that amount of blood going up. So it's a little different than the aortic valve, but you will get a little bit of pulmonic hum as they describe it going forward, and you can hear it in the neck, but it certainly won't be over the over the carotid arteries. So this just reminds you where those locations are at. Okay, so always remember, all patients trust me, and now we're talking about the pulmonic valve. Two things that can be going on there. It's either stenotic with a ejection click or a flow murmur, which is normal. So they could be either or. And then, of course, the regurgitant murmur that we're going to potentially pick up on with the pulmonic regurg or insufficiency is going to occur in that Erb's point. Okay, so main thing, the reason why we care about this is the blood flow, right? It's all about what backs up. So keep in mind that these beautiful lungs that are out here that Dr. Tyrer is going to spend a lot of time talking about, what we're worried about is if the blood goes this direction out to the rest of the body, good, no problem. Issue resolved. But in pulmonic issues where you get the pulmonic artery and it starts building up pressure, where does that pressure go back? Well, it turns it back on and it reverses it, and it comes back into the right side of the heart, causing failure down this way. So all that pressure will back up that system. So if you visualize this, you can kind of figure out what the symptoms are going to be of those patients as you're walking through it. So that's the rationale of trying to visualize and draw out the anatomy. Okay, mentioned this yesterday, but there's a lot of stages of severity of heart failure, stage A through D. And A is the minimal. This is the first part where you know, like hypertension, things like that. There's no structural heart disease, but there's risk. They have diabetes. They have things that are put them at risk for heart failure. So many patients can be in stage A. And then stage one, and this is the New York heart classifications down here with class 1 through 4, and they match up pretty similar. And stage B, which the patient has structural heart disease, but no symptoms. And then stage C, they have structural heart disease and symptoms. Stage D, they're in complete heart failure and having symptoms at rest. It's that basic. And then obviously class 1, 2, and 3, and 4 for the New York heart classification have the similar components to it, but they don't classify by structure. They don't add structure into it. A through D does. So when you're dealing with structure, and what are we talking about? Structural heart disease like ASD, VSD, PDA, all your valvular heart murmurs, that kind of stuff. Okay. So the causes of heart failure are vast, right? We went over the block 1, coronary artery disease, leading to MIs, faulty valves, which we're covering today and did yesterday. And block 2, we'll go over blood pressure, and then all of the wonderful cardiomyopathies. When it pulls the heart, makes it nice and broad, it pulls those leaflets apart and causes leakage. And so those are things that we want to keep in mind that can occur, okay? So always keep that piece in mind as you're going through the process, okay? So these are some of the big key winners that will keep you in mind, okay? Now, yesterday I talked about doing valve replacements, and there's several ways that you can do it. I sent you a little link for a video. One of the key things that they can do is this transcatheter aortic valve replacement. So they actually put the catheter in there, and believe it or not, can actually insert this directly into that valve and without open surgery. It's pretty cool. So yeah, I mean, this can be done in 15 minutes. You can walk away as a cardio PA and make $700 for that 15 minutes. Do the follow-up on the patient with the cardiologist or cardiothoracic surgeon in this case, and then walk away with a pretty good, nice little chunk. So there's some money to be made, and it's a fun procedure. Plus, it's not too invasive on the patient. Believe it or not, they come in the morning and they're gone in the afternoon. So it's not like it used to be. This used to be a massive deal to go in and take out the aortic valve. Now it's not that big a deal. And same thing can happen with the mitral valves. Little different process, but they can replace those valves as well. It's not as easy as this valve to do, but the pulmonic valve can be done in a similar technique. They're developing a lot of least invasive approaches. All right, so check on learning. You've got a 35-year-old female with a history of HIV, presents with increasing dyspnea on exertion. Her temperature is 37 degrees Celsius. Blood pressure is 120/80. Heart rate is tachy. Respirations are 27. Oxygen sats look fine. Physical exam reveals normal breath sounds, elevated jugular venous pressure with large V waves. V waves, what's all that about? And a holosystolic murmur at the right lower sternal border, which becomes louder with inspiration. So it might be a right-sided, maybe. A pulsative liver is there, plus a 2+ pitting edema. Her chest x-rays below, you see this big old heart. And what is most likely contributing to her disease, her dyspnea? So what's causing this dyspnea? So what is the problem? So choose your answer and post that. Okay, good. Most of you are going the right direction on this. Excellent. Okay, if you don't get a poll, just send it to me on your private chats, and the way I got you. Okay. All right, cool. So most of you guys got that. Yeah, obviously tricuspid regurg. Once again, all those waves come back in place, and a large V wave is associated with tricuspid regurg. That's the Villing portion of it, which would make sense. and it's going to be tied in. Plus, it's a holosystolic murmur, best heard at the right lower sternal border, and it changes with inspiration, telling it's right-sided. There's only 3 holosystolic murmurs. What are those 3 holosystolic murmurs? Right? What are the 3 that we want to think of? Yeah, mitral regurg, tricuspid regurg, and VSD, and now you put it together. Bottom line on it is these are the 3 that could be holosystolic, which we've talked about. And the idea is this patient has pulmonary hypertension, and it's causing these symptoms that are backing up on the right side. So let's see why. Okay, let's talk through this. All right, so then now another check on learning. 32-year-old male presents with emergency department with palpitations and occasional non-exertional chest pain. Physical exam reveals a tall, thin man with pectus excavatum. What is that? What are we thinking? Tall, thin, pectus excavatum. And then a late systolic murmur with a mid-systolic click heard on auscultation. Which of the following maneuvers will result in the click later in systole? So it'll change it. So you got to think about what the murmur is. And then, it's Marfan syndrome, exactly what you're thinking. Tall, thin men, long arms is going to give you that thought that it's Marfan's. It makes them a little elastic, easy to pull apart. So which one of these as the poll? Let's see what you guys are coming up with. Majority of you are hitting the right answers. Let's see where you're at with this. Yeah, okay. This is a good one to go over because obviously as you're thinking through this process. All right, so when you're doing this process, what you're really thinking about is what causes that change, okay? So we'll talk about that in a second. So which maneuver, first off, what disease is this? What disease is it? Mitral valve prolapse. What maneuver causes the murmur to move later in systole? Which one do you think is going to do that later in the systole portion of it? So you're thinking, you're right, it is a mitral valve prolapse component. Now think about the maneuvers. What makes mitral valve prolapse louder? Okay, first off, what makes it louder is the 2 things that make it louder are standing and Valsalva, right? So both of those make it louder. And you're right. So as you're going to move it later in systole, you're thinking about what's going to make it change. So you know that it's got to be the opposite when you're looking at what's going to make it later in systole. So squatting is the right answer, correct? It's because there couldn't be the 2. You guys are right. So good. So you think through that process, and you can start visualizing what the heart's doing. It's getting bigger and why it would change it. So during late systole, obviously you see what's happening as the blood's coming this way, and then it goes back. And so your idea is to remind yourself what that mechanical process looks like in that pump. All right, so mitral valve prolapse is that billowing, right? We know that, and we kind of talked through those components. So you guys got your mitral valve prolapse component. So now let's talk about, let's go in and talk about tricuspid stenosis and regurg, and we'll get into these, okay? So we'll start with stenotic lesions. The most common etiology with these is due to rheumatic heart disease, similar to what we see with mitral stenosis. It's not as common, but it still occurs. It can also be congenital or due to atresia, and we'll talk about that. It can also be due to cancer. You can get lung cancer or bowel cancer, and it can cause the stenotic lesions. And sometimes right atrial or metastatic tumors can do this as well. Remember the process. So tricuspid stenosis, increased right atrial pressure, fixed cardiac output from right ventricle, and then we also see some right atrial dilation, and we ultimately wind up with heart failure like we saw in our patient earlier, okay? So that's the process that we got to think through. Now, tricuspid stenosis components, we're trying to tie in the elements here, trying to tie into what are we thinking about that's going to help pull this together. Okay, so tricuspid stenosis is that stenotic valve, blood coming through here. What is that going to sound like? It's going to sound like an opening snap. Where is it going to be best heard? Down here on the lower sternal border, We're going to hear it, and you'll hear that sound. It's going to be best heard with the bell of the stethoscope. And so you can kind of hear it on tricuspid stenosis. You can hear it at the apex as well of the heart, but it's just separated out from complexity, so you don't run into the issue trying to separate out, is it mitral valve or tricuspid? You're better to listen here and pick it up. I agree with the diagram that you would probably hear it the loudest at that apex, but that's how you separate them out. But what really tells you the difference is the inspiration versus the location. So changing with inspiration. So the loudest, where they're loudest at, this just reminds you of it. The tricuspid valve, what we want to remind ourselves is that most of these are going to be in between these two spots that you're going to hear them. There's not an exact science, but it gives you an idea of where those locations are best heard at. All right, so signs. Remember the clinical features that are going to remind us that it is tricuspid valve. Well, first off, there are similar diseases that are associated with mitral. We're going to see venous congestion, abdominal distension, hepatomegaly. Patients can have peripheral edema, fatigue, palpitations. And one of the things that they can get is those giant A waves due to the stenotic valve. So it's stenotic, the atria contract against that stenotic valve, the blood goes back up into the neck, and you get these giant A waves. So that's a very common thing. It'll look like atrial pulsations, but it's in the venous system, and so they're different. So Cannon A waves are associated with third-degree heart block. Giant A waves are just large. They're a little different. They're described a little different. Cannon looks like a cannon. I mean, it's shooting out. These are just big. They don't necessarily change in the speed of them that you see, because there is still blood going through the stenotic valve, just not as much. So it's a little different. Not a great key indicator. All right. So what do you see? It's on physical exam, or here. It's low-pitched, rumbling diastolic murmur, just like you hear in the mitral location. It's best heard with the bell. It's difficult to distinguish between mitral stenosis, but we do it based on inspiration. This is the key. So if you had a patient with a murmur at the apex, okay, that you hear in the fifth intercostal space, but it accentuates with inspiration, call it a day. Now you know it's tricuspid, it's not mitral. So that's the key. If it changes with inspiration, it is a right-sided murmur, and that's the importance of knowing that, okay? And once, like I said, you can hear it best in that location, sometimes at the apex versus over here on the left sternal border or right sternal border. It just depends. So you separate this out. The key differentiator is the inspiration. Everybody tracking. Everybody tracking. Don't get lost on that one, okay? All right, so murmur. It's accentuated by inspiration. Beat that up several times. And the reason why is it's so important. That's the number one thing to do that. It does. So mitral valves aren't. Mitral valve will decrease. Will change its or will be accentuated with expiration. Tricuspid valves have no effect. So right-sided valves are or you hear them accentuate with inspiration. Expiration doesn't do much to right-sided valves. But expiration will have a massive effect on left-sided. So that's really one way to help separate them out, okay? Yeah, so you pull it out. So leg raise, squatting, all that increases preload component, and that'll get you there. All right, to be clear, tricuspid regurg can be heard at the right sternal border, left sternal border, and the apex. Correct. Yes, that is correct. Be clear, it can be. And it can be heard at all those locations. What distinguishes it is the change with inspiration. Okay. All right, moving on. So now you can get right atrial enlargement, which of course can occur. It can be with the absence of right ventricular hypertrophy, or it can you can have it either or. So you can see with right atrial enlargement, makes sense. It's stenotic. And so the component, some patients will develop right-sided heart failure as this goes on. It starts backing up, right? It makes sense. So you'll see that right atrial enlargement. Echo is confirmation. Now, the treatment to this is pretty easy. It's diuretics. It's right-sided heart failure treatments. So furosemide, which is Lasix, is very common. Should suggest the diagnosis of tricuspid stenosis. Not sure exactly what you meant by that, but yeah, an opening snap suggests a tricuspid stenosis on this. Yes, it suggests it. Yeah, so it suggests it. Diagnostic test echo will can confirm it. These suggest, this confirms. This is the confirmation test. Echo will confirm all valve diseases, transthoracic, okay? So now, surgery is usually reserved for patients undergoing other valve or CT surgery. Once again, we want to do the least invasive process. If we can do balloon dilation, we'll do it. We can also do valvotomy, where we open the valve, or commissurotomy, but these are open procedures. We have to open it up. And then sometimes we can do a valve replacement, and they are getting smarter to do those least invasive with a camera. Now, we're going to describe regurg. Regurg is a very important process on the right side. It's the most important one. It's a level 3. It's due to many things: dilated right atrium, right ventricle composite. So anything that's pulling the heart apart, like cardiomyopathy, where it dilates the heart, can do it. Pressure or volume overload. This is why I gave you guys that S4 question on block 1, because that's and it can be due to either one, right? Pressure can do it, or volume overload. Both can cause that. Wedge pressure to be high can be due to either one. And so it's hard to differentiate which one it is. Bottom line on it is it pulls the valve apart and causes leakage. So rheumatic heart disease has the same process that can lead to it, where we get pulmonary hypertension and right ventricular enlargement. IV drug users, very common. Right-sided, they inject the drugs into their arms. It goes to the valve, causes it to leak, and that's why you see it. And then there's congenital causes. Mom taking lithium, mother taking lithium, child develops a congenital cause, which then leads to a congenital tricuspid regurg, which is usually called an Ebstein anomaly, which is the congenital element to it. So Ebstein anomaly is always 100% of the time associated with the tricuspid valve. It's always on the right, and it's most of the time. There's other causes, but very rarely is it just congenital. It's usually due to medication. So mom's bipolar, taking lithium, and the child develops this. Okay. So carcinoid syndrome is rare, but when it does happen, it comes from cancers out of the GI tract and lungs, which can cause tricuspid regurg. It's rare, but it's on every exam. Okay. Every exam will talk about that. Now, what is Ebstein anomaly? It's that rare defect of the tricuspid valve. It looks like this big hole, it looks like one big, large chamber, and it hasn't properly formed. You can see why that would be a huge problem for the patient. And most of them have an associated ASD with it, which would have a fixed split S2 and would, complicate the patient's symptoms. And check on learning what most commonly caused this situation. What drug did the mom take? Yeah, lithium, exactly. All right, so tricuspid regurg, we see right atrial dilation, increased contractility, increased pressure in that right ventricle. That can cause right ventricular hypertrophy and eventually heart failure. Everything leads to heart failure, right? So your job right now is to figure out, how did that valve lead to heart failure? And if it's on the right side, what am I going to do about it? Right-sided heart failure management, right? And then if it's chronic, it's the same pathway, doesn't change, does the same thing, just it's slower. All right, signs and symptoms: peripheral edema, right-sided heart failure symptoms, fatigue, non-specific, but a constitutional symptom. Notice patient comes in with fatigue. Well, first thing you should think about is heart attack. Second thing you should think about is congestive heart failure. Third thing you should think about is pulmonary embolism, things like that. So you're going down that pathway like, oh man, it could be something more serious. And all of these patients, just like on the left, can develop AFib because you stretch the atria, it makes the foci irritated, and it'll cause atrial fibrillation. Patient will have abdominal fullness, can be due to ascites from fluid backing up on the right side. And they'll have that prominent V wave that we saw, learned about in block 1. So that JVP is important to remind ourselves. This just is a curve reminding you of all the valves, what that waves are doing through the process. Just to keep in mind that once again, pulled back from block 1, that JVP is important. All right, clinical features. You're going to get a heave, okay? Why? So I got my hand on the right side of my heart and I've got tricuspid regurg. The regurgitation is coming back from right. So the tricuspid valve shoots into the right ventricle and then it splashes back. Well, I'm going to feel that on my hand. It's going to heave, okay? And then I'm going to feel in my belly ascites. I'm going to be ascites or peripheral edema. I'm going to feel the right side of my liver and feel it pulsating because the right side is backing up, so I'm getting fluid in it. And then severe tricuspid regurg, these patients can be cachectic, which means they're losing weight, sick looking, chronically ill. They're crunched up, they're in bad shape. So they're going to look like a pink puffer for COPD example. These cachectic patients look really, really sick. Okay, so you're going to admit them. Okay, if you see this on an exam, that's going to tell you this patient needs to be admitted. And then the murmur is a blowing holosystolic or pansystolic murmur. It's best heard with the diaphragm at the left lower sternal border, and it also intensifies with what? Inspiration. So it's a right-sided murmur, makes sense. It diminishes with Valsalva and standing, right? Valsalva and standing diminishes it. That's the key. EKG, we're going to see all of the same things that are going to suggest it's on the right side. Chest X-ray, right side. And what are we going to confirm the diagnosis with? A transthoracic echo. Okay, that's what we're going to do. Treatment is for isolated tricuspid regurg. Normally, most patients don't have a big deal. They're fine. We just treat the underlying cause, get them off the drug use, find the problem. Diuretics are to treat for volume overload and congestion. If they have it, most of the time, it's mostly due to volume overload on the right side. So Lasix works really well. In severely symptomatic patients, we might need to do valve replacement, okay? And once again, least invasive is what we want to do. So those are the complications associated with the tricuspid valve. Pretty straightforward. Those are the ones we want to remind ourselves. All right, so now we're going to jump into pulmonic valves, okay? Second left intercostal space, it lies right here. That's what we're going to listen to, and it's going to give us a key to this process. Now, what we're going to talk about first is the ejection click of pulmonic stenosis, and it's similar in etiology of what you see with aortic stenosis. It has some other causes. One of the main things that you got to remember is that it can be congenital. That's the most common cause of it, if it's there, and carcinoid syndrome. Once again, this is due to a plaque that builds up and it builds up as a result of a tumor in the GI tract or the lungs, and it'll affect the right side of the heart. Now, what causes this process? Pulmonic stenosis, increased right ventricular pressure, right ventricular hypertrophy, because it's got to the right ventricle's got to get big and push that blood through there. And that causes right-sided heart failure. It's on the right side, so it makes it easy. And initially, there's no dilation and no heart failure, but as time goes on, it will. And these patients will, if they have complications like an ASD, which will have a fixed split S2, or pulmonic insufficiency, which is going to be best heard in Erb's point, is going to really tell you that that's a problem. Will this produce tricuspid regurg? It can, because it can force it. Absolutely. Pressure over time will lead to it. So right heart failure typically occurs in their late 50s, or, so later in life in the 50s. Okay, that's usually when you see it. Children, what we see is with pulmonic stenosis, they typically do, if we see it, We got to be concerned about tetralogy if low. That's the most common thing that needs surgical intervention, but they typically do okay. And then, of course, they can be asymptomatic initially when they get this. Eventually, though, they'll get exertional dyspnea, exercise fatigue, syncope, and they can also develop, right-sided heart failure type things. So tricuspid stenosis, I'm not sure. I had a question about was the actual treatment of choice for tricuspid stenosis. So tricuspid stenosis, let me just make sure you guys understand this. Any stenotic valve, that's always the same thing. Initially, if we can do a balloon, that's going to be preferred over complete valve replacement if we can do it, if it's allowed. So that's going to be the idea. So that you're thinking through the process, that's going to be typically the way you want to approach those. All right. So keep that in your back of your mind. So stenotic valves, typically, if we can do minor adjustments and keep the patient without having to go through a full open procedure, that's what we want to do. Okay. And then medications for right-sided are going to be usually Lasix driven. Lasix, which is furosemide, is going to be the key drug that's going to help you drop that volume. Okay. All right. Moving on to the clinical features. So physical exam findings correlate to the severity of that stenosis. That makes sense, right? And so one of the key things to remind yourself is that if the more severe the stenotic valve, the less you hear the P2. It gets quieter, right? So it gets quieter, which is weird. So, and that's one thing that throws you off. Now, there's this thing where you get a parasternal lift. Why? Think about it. I'm in the second right intercostal space, second left intercostal space, and I'm getting a lift on both sides. Why is this happening? It's parasternal. That's right. It's parasternal. I'm feeling both sides. Why? Because the stenotic valve, in order to get it through there, I can lift on both sides, so I can feel this like a lift, and it's an impulse from that pressure trying to get through there. Just imagine trying to get through I imagine I'm the blood. I'm trying to get through that stenotic valve. I'm pumping. I'm hitting the chest. That's what I'm doing. I'm getting that parasternal lift, and so it's common. So you'll feel that impulse, especially in the second left intercostal space. That's where it's predominantly going to lie. You're going to feel it the most on that side. If it's an aortic stenosis, you'll feel it predominantly on the right side. You can feel it on both sides, but it'll be more predominant on the location where the valve is going to have the issue. Okay, so a splitting of the S2 results in prolonged ejection. So this is key, right? This is the wide split S2, right? Wide split S2. Wide split S2 causes that association with pulmonic stenosis. Okay, can also be associated with a right bundle branch block. Okay, so you get a delay in that pulmonic component, and that is the key. Wide split S2 is what you see. Now the S4 may be heard at that left sternal border. Why? Well, it's a pressure overload situation, and that's what's causing it. So murmurs, you're going to get a crescendo, decrescendo, best heard with the bell. Is where I like to use as an idea for to really hear it good, but you can use the diaphragm as well. You can pick your choose depending on how severe the murmur is. The bell sometimes, that's why you listen with both, because sometimes one will be better than the other to pick it up. The diaphragm typically you'll hear the murmur it'll pick it up as a loudness, but if you want to hear the ejection click, you probably want to switch it over to the bell and let me tweak that a little bit and I can hear it. So it's key with that component. So the P2 gets quieter as the murmur itself increases severity. Good job, Trina. Yes. Same thing with aortic stenosis. As it gets more stenotic, it gets quieter. And that tells you it's getting more severe. So yeah, that is exactly what you need to take away. The more severe it is, the quieter it is. And that's crazy, right? It doesn't make common sense, but when you think about it, it does, because as it's stenotic, there's not a lot moving, right? The more stenotic, it's really, really narrow, nothing's moving. So you're not going to get a loud ejection click. The wider it is, it's going to hear more of it. So that's why. It's the same theory why when you do it, you have a VSD. The bigger the hole is, if it's a big VSD, it's quiet. If it's really small, it's loud as hell. ASD, same way. ASD is really small, loud, loud, loud. Big ASD, can't hear it. It's just crazy. It's counterintuitive to your thinking. But yeah, that's the way the heart works. All right, so often this is accompanied with an ejection click on your exams. It will always be associated with it, okay? So pulmonic stenosis, again, you're gonna do baseline imaging for looking for right-sided issues. We wanna get an EKG because we're worried about AFib and other things that can develop with this. Do an initial transthoracic echo, and it's repeated every 5 to 10 years, looking for the severity of this. And we always start with the transthoracic and really look at that. You said little kids are loud, and that stuck with me. Oh yeah, exactly. And evaluate the severity of this utilizing 2 and 3 dimensional. You can check it with the Doppler so you can see the blood flow. That's what you want to do. Now, if you're going to do a cardiac cath, it's going to be done on the right side, which is a Swan-Ganz, and we can check that. And what we want to do is look for people that had a Doppler done, which is an ultrasound. If looks like their pressures are really high, and they might be a candidate for a balloon valvotomy, which is that balloon stenotic valve. Going back to one of the questions that was asked earlier, what's that? If it's stenotic, what do I want to do? I want to take it, put a balloon in there and try to dilate it. That's step 1 in the process. Okay, so what is the treatment for pulmonic stenosis? Really severe cases, surgery. So if you had a test question, which you might, that said the pulmonic valve was very almost inaudible now, and the patient has severe dyspnea on exertion, and it asked what's the best treatment, surgery would be it. So you could start with a balloon valvotomy. That might be effective. If it doesn't work, then you have to do open surgery and replace it. And then you treat the underlying right side heart failure. That's the key. So if you can't hear the pulmonic valve and they've had pulmonic stenosis for a long time, consider it pretty severe. All right, so insufficiency. You measure the gradients through the Doppler. So remember, Doppler ultrasound is how we get the initial flow. So when I look at it with a transthoracic echo, I get an estimate of those pressures. Putting on the Doppler, I can see, hey man, the pressure might be this. It's an estimate, but this is what it's saying. The ultrasound gives you an estimate. So if it's greater than 36 millimeters of mercury, then that's it. So if it was so severe and they're symptomatic, we can jump to surgery if they're a candidate. Absolutely. Yeah, gotta definitely refer them to it for sure. And our job as primary care PAs is to refer. So you're not going to set on this. You're going to refer early. But if you got a late patient, which that happens, patients wait till it's too late, and that can be it. Pulmonic insufficiency. This is a flow issue. And it's usually due to severe pulmonary hypertension. Check on learning. What is one of the key physical exam findings to diagnose pulmonary hypertension? It'll should pop right in your head. Loud P2. Yeah, exactly. You hear it, should think it. And it can cause severe regurg. Infective endocarditis, which we're going to talk about today, and rheumatic heart disease, both can do it. And then in kiddos with brand new babies can have tetralogy of flow. And they have 4 defects that are very common. They'll have a VSD, a hole in the heart. They'll have a pulmonic valve stenosis, right? So this is the one we're worried about right now. And they can have a misplaced aorta and a thickened right ventricle. That's the 4 things they can have. And we'll learn about this in block 3, that you can also have a tentology of flow, which adds an ASD to this, making it 5 abnormalities for these kids. This is a level 3. You need to know everything about tetralogy of flow. Okay. Pulmonic insufficiency. You want to know how it works. So pulmonic insufficiency is a regurgitant flow. Increased volume. It causes the wall tension in the right ventricle to be under stress, which leads to hypertrophy and eventually right side heart failure. So it's the same process each and every time. What are the symptoms? Well, most of these people are asymptomatic, but they can have exertional dyspnea, which is always a problem. They will get angina due to subendocardial hyperperfusion. And what is this? What are we concerned about here? Non-STEMIs, right? That's what it does. It leads to non-STEMIs all day long. And this is why we worry about it, and it can cause it on the right side. And then, of course, exertional syncope is common too, due to the inability of cardiac output during activity and fatigue. This is exactly what some people are concerned about when you run around, like for those of you that are into real heavy PT and you wear a face mask and you run and exercise with it. Well, you can cause yourself to develop early pulmonary hypertension. So if you run with a mask, so that's one of the concerns we have when you're in full MOP4 for soldiers, is that pressure can lead to, over a period of time, to exertional syncope and acute pulmonic insufficiency that leads to all this. Notice that fatigue is a constitutional symptom in all of these, so you got to be thinking about. Could this also cause arrhythmias like left-sided? You bet. Absolutely, Mike. Anything that's putting pressure in the heart, making it bigger or altering the left or right ventricles, those are exactly the kind of things that we need to be thinking about that can cause arrhythmias. That's the issue, right? There's three parts to the heart. It's either a conduction issue, it's either a mechanical issue, right? Or it's something outside the body that's influencing the heart. Those are the three things. And we have to figure out which category that's in. If it's mechanical, we got to fix that. If it's electrical, we either augment it with a pacer or implant cardiac defibrillator. And if it's something else, then we got to fix something else. If it's anemia, thyroid disease, whatever it is. And that's what we're trying to do. We're trying to figure this out. We're trying to sort it out. So now when we think about insufficiency, think about pulmonary edema, right-sided. It's going to cause increased right-sided cardiac pressures. Makes sense. What's the normal cardiac? Remember, I told you need to know the pulmonary pressure. What is the normal pulmonary pressure in somebody on the right side? What's the typical pressure? 25, exactly. So you have that range. If it's greater than 25, start looking for something that's bad. And this can cause patients to get swollen abdomens, which will cause anorexia and abdominal pain. And that's due to hepatic congestion. And then there's other less common symptoms that can be cough, hemoptysis. Oh, the second case of where hemoptysis is there, and then hoarseness, which is due to compression of that recurrent laryngeal nerve, which is called Ortner's syndrome. Okay, so when you see this, this is what we got to be concerned about. Think about this syndrome, so it can be caused. Enlarged pulmonary vein against the right recurrent laryngeal nerve. That's correct, and it's exact same thinking. You know, I told you yesterday. You know, mitral stenosis causes left atrial enlargement, and it will do the same things. It either will cause pulmonary hypertension or it will compress against the trachea and the esophagus, leading to the things that we discussed yesterday in that mediastinal space. So all of those are possibilities. The bottom line on it, this is the second cause of hemoptysis and murmurs. All right. Now, insufficiency clinical features, the murmur of insufficiency is usually early diastolic ejection murmur with an ejection click in the pulmonic area. That's the pulmonic component that we can hear that sounds similar to what you would hear with pulmonic stenosis. But the difference is that it's in the context, what you're hearing now is it's in diastole. That's the key. It's in diastole, even though it sounds like an ejection because of the flow through that valve area. That's what you might hear in that second left inner space, but it's in diastole. And then you hear the blowing component in the Erb's point that helps confirm it. So the reality of it is because that valve is being blown, you get this flow going through it and it comes back, you can hear something that sounds like an ejection click. But you confirm it though because it's in diastole. Pulmonic stenosis occurs in systole. So that's the key, and that helps you differentiate them. So Graham's-Tail murmurs are the result of pulmonic hypertension, and they can be indistinguishable from other murmurs of aortic regurg and pulmonic regurg. The association, you can't tell the difference. So what gives it away though is a loud P2 and they can have this high pitched decrescendo diastolic murmur heard at that left sternal border associated with pulmonic hypertension. So that's the Graham-Still proportion of it. So very difficult to differentiate those. On exam, you're not going to be responsible to sort out that complexity. You just need to be aware of what Graham-Still is, what is it associated with. You'll see that on your boards. Okay, so pulmonic insufficiency, regurg, what do we do? Transthoracic echo first, and then look at right-sided stuff. We're going to see, might see some prominent veins, but it's really all looking for right-sided heart failure. Now, our treatment is, in severe cases, is valve replacement. We want to treat the underlying cause, so pulmonary hypertension. So pulmonary hypertension, luckily, is treated like many other things that we do with congestive heart failure. And we use the acronym LMNOP that you're learning in, hopefully you're learning this in pharmacology. You'll talk about this, but it's Lasix, oxygen, morphine. We'll go through the nitroglycerin, and we go down, and you're really learning about all the drugs that can affect heart failure, can also treat pulmonary hypertension. That's the good news. We're going to get into more detail of these this afternoon, actually. So we'll talk about that later. So the need for diuretics, oxygen, and anticoagulant therapy needs to be addressed because you've got this stagnant blood in there, and you need to think about that it could cause a mural thrombus. What is a mural thrombus? Okay, blood, here's the right ventricle, right? All this blood's coming in this way, and it's stagnant. It sets here, and it develops a clot, right? And it just sets there and swirls, and eventually that can wind up in your lungs if you don't do something about it. Okay, so now we'll take a break, and then we'll go into infective endocarditis. This is the fun stuff. I love endocarditis. So should you, as you go through it. So I'll pause. Well, actually, I won't pause the. I'll keep that going. I'll just put us on break. Amy, good question. Yeah, so the echo and transthoracic echoes, consider them in the same thing. They're ultrasounds. Okay, so keep that in mind. They're ultrasounds. So that's all it's doing, and you can estimate the pressure. They use this equation called the Bernoulli equation that allows you to assess the pressure through there, and you can get an estimate of that pressure. So it does give you an estimate for it. So there's different ways to kind of confirm that. But echo and when you're talking about ultrasound, you can kind of consider them in the same way. You add Doppler that shows flow, okay, and the Doppler just helps you figure out those pressure lines. Adam said, "Is that because the overriding aorta and VSD caused the anatomic stenosis?" We don't know. Like I was saying, Adam, we don't know if it's due to the actual pressure on it, or if it's due to the fact that the tissue itself isn't developed. Nobody knows. And so it's kids are born with it, and we have to operate on them. But yeah, you can't. Unfortunately, congenital abnormalities. This is something. If you figure it out, you're going to be rich, and there'll be something. If Adam gets it, it'll be the Adam disease, and so then you'll figure it out and make lots of money if you uncover this. All right, so let's go into infective endocarditis. Amy, did that answer your questions? Okay, good. All right, so let's jump into infective endocarditis and walk through these processes. So this is a fun one because lots of things can cause infective endocarditis, and this is a high stake issue for PAs. We get sued a lot on this because we miss the diagnosis. So let's don't miss it. So we're going to talk about physical exam and diagnostic procedures and jump into it. Makes it fun to not do that. You want to make sure that as a diagnostic clinician that you don't miss these things. So we're going to talk about all these tasks and go through them. All right, so we're going to jump into the different things. So infective endocarditis, it's defined as an infection, right? It's usually bacterial on the endocardial surface of the heart. So we're going to talk about all these. We'll get into all the details, but this is the new updated 2020 definition, okay? Now, what is the key with these? Well, it's on the inside, so it's usually from bacteria getting into the blood. How did it get in? It can come from your mouth. You get bacteria in your mouth all the time. It gets into the blood, circulates the heart, and then it causes problems. So there's a lot of different ways it can occur to get on the surface, and there can be an underlying nidus or source that causes it. So if there's a valve issue, something along with the tenon along there is an issue, or if there's vegetation occurring from a variety of reasons, if there's morantic, non-thrombotic issues going on, and we'll talk about what that means, but you can have non-bacterial causes like associated with autoimmune causes that do this, as well as you see a high mortality if it's untreated, okay? So the bottom line is most of it's due to males, and you'll see why. A lot of them are IV drug users that can do this, that can lead to it. It's very common in IV drug users. And the valves that are most commonly affected are usually on the right side, and it's associated with it. So you got to remember that these valves are very common. IV drug users are those people that we're worried about the most, with the tricuspid valve being most commonly affected on the right side. If it's not due to the IV drug users, the mitral valve is most commonly affected, and then it goes down the pathway based on the way the heart flows. And that makes sense. First valve to be exposed to the bacteria, and that's why. So mitral valve prolapse without drug user is the most common underlying condition with infective endocarditis. So that's important to know. And so when you look at it, they have a significant risk. It's almost tenfold over the population. And then always remember that anybody who had previous endocarditis, they're at high risk of subsequent cases. So if they've had it before, chances of them having it again are high. Most cases are due to the damage of that endocardial surface. And then we're going to get into the organisms that do that. So this is just the explanation of the different valves that can be affected, to put it in your mind that there's many, many, many causes. The one I would highlight is the fibrin platelet aggregates that can occur because of damage, just like a artery that has an endothelial cell damage. If the heart or somewhere gets a damage, it can lead to non-bacterial thrombotic endocarditis because it builds up this thrombus that's not due to bacteria, and it can be autoimmune or others. So this endocarditis may occur in very severe illnesses, or you can see merantic endocarditis as an association with malignancy, very common with malignancy. And then there's these wasting diseases that can happen, and there's many of them. We're not going to go into a lot of detail about them, but they're there. And then there's a thing called a Lehmann-Sachs endocarditis, which is associated with lupus. So Lehmann-Sachs is another term for an autoimmune source that can lead to these processes. And when that bacteria occurs, you see basically like from the gingiva, teeth cleaning can cause previous sterile vegetations can be seeded. So if you have lupus and you've got this thrombus that's building, and then I clean your teeth and it goes down to that valve area and then gets the bacteria that's in your mouth, usually Strep viridans, and then it will cause endocarditis. That's the source. This chart is a moneymaker. It'll help you on the boards, and you need to know it cold. So native valve means it's never been injured before. IV drug user, those folks. Those that got a prosthetic valve, surgery less than 1 year, and those that are greater than 1 year. Those are your 4 options or categories. So strep, if you look down here on the bottom, includes viridans, which is the most common cause. So you could just add viridans to the top of this. So Streptococcus viridans, strep viridans is the most common. If you've never had any scarring, it's the most common. If you're an IV drug user, Staph aureus. If you are getting a prosthetic valve, it's due to Staph epidermidis from the skin. So when they're doing the surgery, they can seed it with early on during that year, you can get Staph epidermidis. And if it's greater than a year, then it goes back to Strep viridans as the most likely cause, mainly due to scarring. So it kind of puts it back into the native category, but there's a nidus behind it. And so it changes some of the organisms that might be likely to it. And then you got the list below them. You're responsible for knowing the first and the second layer of these other organisms, not as much, but you need to know the first and second for each of these, okay? And know that the other one that's important is if you see it, if you got somebody who came back with strep bovis, is going to be associated with GI malignancy or liver cirrhosis. And then the HASIC organisms, which you guys have learned previously and you're learning them in ID, are all the ones that are very common with these. And then there's some one-offs, and we'll talk about those. But IV drug users are typically going to be associated with staph. Okay. Check on learning right off the bat. 56-year-old female with a history of mitral valve prolapse, right? The most common lesion that causes infective endocarditis, has been experiencing fevers and joint pain for 3 weeks. She recently underwent a tooth extraction. So she got the bacteria going up, right? Physical exam reveals a holosystolic murmur at the cardiac apex, which is not present on prior exams. So it's a new murmur, new fever. She has an ESR rate that's elevated. Painful nodule on the pad of her finger. What is that painful nodule that developed? What is the most likely culprit? So figure out the organism and think about what is that cause. Yeah, ocular nodes, that's right. And that's separated out from subcutaneous nodules and rheumatic fever that are painless, right? So ocular nodes are painful. Painful things are bad news. So they just don't do well. And so, yeah, you guys are on the right track. Got it. Okay. Moving on to this. So you've got a majority of you picked the right answer, strep viridans, right? So subacute bacterial endocarditis, most commonly due to strep viridans, mixing in the mouth, and that's the most common cause. And this explains the rest of that for you. All right, so let's jump into the pathogenesis of infective endocarditis. What is the problem here? So males are more common, age and male and being older than 60 are risk factors, okay? And then structural heart disease, anything that causes the structure could be an issue. So if you had a history of rheumatic heart disease, it scars it, okay? Mitral valve prolapse scars it. Aortic stenosis and aortic insufficiency causes scarring, nidus. That's the nidus. And so the prosthetic valve can also lead to it during that first year, and we know that's strep epidermidis. And congenital disease. So if you have a bicuspid aortic valve, which can lead to aortic stenosis in young people, right, or any of the other congenital causes, we know, especially tetralogy of Fallot, that's why we care about it, is that these patients are at risk for infective endocarditis, okay, if you have the history. So you have the four components to it: the overriding aorta, the right ventricular obstruction, the VSD, and the right ventricular hypertrophy. This right ventricular outflow obstruction is what? That's pulmonic stenosis. And so it gives you some key things on that you'll see that the child will be cyanotic during infancy. They'll have a boot-shaped heart and a very loud S2, single loud S2. Why? Because the aortic valve, the pulmonic valve is closed and the aortic valve is doing all the work. So that makes sense. And then they're going to have a harsh systolic murmur that's going to be associated with pulmonic stenosis because it's trying to get some through there. It can't get a lot through that area as it's diverted, right? Because you got the diversion that's occurring because that overriding aorta. So it's a really problem. So what does the kid have? They're going to be crying. They're not going to feed well. They're going to have that pulmonary flow obstruction. Squatting actually helps because it enlarges the heart, which then improves their ability to get blood circulating, and squatting because it increases that vascular resistance, allowing them to get more blood circulating. That's the idea, okay? Endocarditis, the big thing is indwelling catheters or IV procedures can seed it. So we can give a normal IV and or an indwelling catheter and cause the problem. So that's an iatrogenic cause in Vindicate that can cause infective endocarditis. IV drug users can do it, obviously. And anybody who has a history of infective endocarditis, high risk. They had it previously. Poor dentition in their mouth can lead to strep viridans and then be an HIV positive, autoimmune, okay? Other things that we got to think about is the exact same pathophysiology that we've thought about before. Something on the surface that gets injured. Those cells, the endocardial cells get damaged. It leads to the same pathway that we saw previously with platelet aggregation, bacteria circulation, and that adherence on the surface. It's actually very similar to the same thing we see with atherosclerosis, but on a bigger volume inside the mural area, which is along the ventricles. Most common cause is turbulent blood flow, okay? So it damages the surface, and then the platelets adhere to it to fix that damage. That platelet builds up, and then you get these fibrin deposits, kind of like what you see with thrombus, and then bacteria enters it, and then what you see is the bacteria lodges in those platelets and then starts growing. And so the body can't get to the bacteria to remove it, and when it can't do that, then it just starts its own process. Instead, since it can't remove it, it just sits there and gets big. So these bacteria can lodge in lots of places, and then what happens is we get a mechanical injury from whatever reason, whether it's due to a heart attack or the heart gets bigger, it stretches it, so it flies off. And then when it flies off, it becomes septic, and it goes to your brain, to your legs, other places, can cause strokes and really have a real problem. And then you get this immune injury that's due to like lupus and diabetes and other things, and they can cause the antigen antibody deposition around it, further aggravating the situation, allowing fluid. It's kind of like a sinus infection. We have bacteria in our sinuses that live there. It's fine until we get too much fluid buildup. You need fluid in order for bacteria to grow, and that's what this provides. It's kind of same thinking. But this is what you see. This is a bad, obviously this patient didn't do well because of obviously the damage that can happen from this is very dramatic. So you would try to avoid this with those injuries. These are examples of different pathology that you'll see with where the scarring is occurring, and you can tell where the areas of damage that are occurring in the heart are. Now, what we want to do is figure out who has it. Well, usually these patients come in, if it's staph infections are the worst ever, because on the skin, you can live with them. Once it's in your body, it's a bad news. It's usually what kills you. It's a bad deal. It rapidly, high fevers, chills, very, very common. So IV drug users, they don't do well with this. It can kill them, and it happens. Strep infections are the opposite. Strep usually causes low-grade fever and non-specific constitutional symptoms like fatigue. And that's why you could have an infective endocarditis for months and not even really know that you have it. So you can have chronic disease with this crazy stuff, and it just keeps coming, because it's kind of, you just feel bad today, and then it kind of gets a little better, and then it gets worse, back and forth. So you got to have a high index of suspicion for it. Most of these patients, though, will complain of fever, fatigue, malaise, weight loss. And most of them will have this musculoskeletal pain from arthritis and myalgias, and a lot of them will have back pain as a complaint. So this is a very key thing. PAs. This staff sergeant shows up right to your aid station and keeps coming back with back pain and a low-grade fever, and he's telling you about it. But when you check his vital signs, they're always normal. So you're like, he's a malinger. He's malingering. Maybe not. So that's why importance of reoccurrent patients that keep coming back. Don't think that way. Think other things. Think broadly. What could it be? And this could be the cause. And so you want to think that way. Now, history of present illness. That's your package for all diseases. It's fever, chills, new onset murmur, weight loss, all the same things. This could be many things, but infective endocarditis can kill you. So you've got to put that in your mind. And then always remember that it can present with valvular disease and congestive heart failure, because that's going to be a component, right? Those are really important elements to keep in mind. And as a reminder, that these things can lead to strokes. They can come out and be an emboli and move forward. They also, with IV drug users, can have some unique complaints associated with that. Because of its staph component, it's going to be on the right side. They can get this emboli that shower the pulmonary vasculature system that look like a bunch of pulmonary embolisms. And so it's very important to remember that in the case of infective endocarditis. So it can be subacute, which is chronic, usually due to what organism? If it's subacute and chronic, what organism is usually causing it? Yeah, it's strep. If it's acute infective endocarditis, high fevers, it's usually staph. So that's the main difference. That's how you kind of keep them in those categories. So these are the key features. So high fever, think about that. Always think about the sign and the symptoms. Symptoms are vague, but one of the key things that you'll have is, so if you hear fever and a murmur, you better start thinking endocarditis. Fever and a murmur should make you think that. Then you look for other things: skin lesions, petechiae, things that are making your infection that would high likelihood that there's something else going on. Moderate symptoms can these patients come in with moderate frequency and symptoms. They can come and go. So it's very, very important to keep your mind on this, that patients that are going, hey, I'm sweating every other day, I'm associated with a little bit of weight loss, I've got this cough that comes and goes, stroke-like symptoms, TIAs early on, rash, nausea and vomiting. These are all non-specific, but should make you think, boom, let me look for other things. Then I start seeing painful nodules on the skin, or Janeway lesions, which are really just petechiae. They're flat lesions on the hands that are painless. So Janeway is painless, Osler is painful, and then splitter hemorrhages are going to be common on the nails. Always look at the nails. Remember I told you, look on the fingernails. If you see something, man, it's probably going to be bad. So stroke, heart failure, pneumonia, and meningitis can occur. Any of those infections can spread anywhere in the body. And then if they're low risk, these are things, low frequency patients have these symptoms typically. So when you're thinking about the frequency, this doesn't happen very often, but you always want to remember that some patients with infective endocarditis will only present with abdominal pain. They could present with delirium or coma. And all right, here's the third time So we've had hemoptysis from mitral stenosis, hemoptysis from what? What else did we see hemoptysis in? We just talked about it earlier today. Hemoptysis was in mitral stenosis, pulmonary insufficiency, and now we see it in infective endocarditis. We're building our differential, okay? And this is a rare sign. It only occurs in about 10% of patients, but something you need to think about. But the key with this is they're going to get retinal lesions, okay? Roth spots in their eye, hemorrhages that you can see with these. And then they'll have renal failure as a very likelihood. So their bun and creatinine levels will be high in those cases. Okay, so the number one thing that should make you think about a patient having infective endocarditis is fever and new murmur. Okay, then you order lab tests. You get a CBC and you get an ESR. You're looking for urine, looking for blood in the urine, hematuria. And then also consider looking for chest x-ray, looking for pulmonary findings of effusion, infiltrates, and potentially septic emboli like we just talked about. Roth spots, which is really rare, but they do occur in about 10% of the patients. Janeway, which is painless. Osler nodes, which is painful. Splinter hemorrhages, which is on the nails. And then splenomegaly, and then things that might suggest embolic event. Worsening of a previous murmur, this is very common. You'll have it in the lab. We'll talk about a case where guy had a VSD, now it's getting worse, and that is the nidus for it. So these are visual cues, Osler nodes, petechia, okay? So these are painful, these are painless. You can see them elevated lesions there, and it's pretty common. So those are visual cues. Now, what you want to do is use the Duke criteria to diagnose endocarditis, okay? What is that? So there's two types, two things it could be. It's either definitively endocarditis, you've got it, no doubt about it, or it's possible, okay? One of the two. And we figure out based on this Duke criteria which one it is, okay? And it's based on us looking at labs, our echo for the murmur, EKG, and our chest x-ray. We look at all this stuff and put it together. Now, here's what we do. We get a good detailed history, right? We want to make sure, are they an IV drug user? Did they recently have something that was iatrogenic? We want to look for those things. We want a detailed exam. We're looking for new examples of heart murmurs. We do a good detailed cardiac exam. We look for Osler's nodes. We look for Janeway lesions. We get blood cultures, which requires us to get blood from this arm, and another location. So we try to do it at least in 2 different locations and sometimes 3. And we space it out over time so that way we can really confirm whether we accidentally put the staph in the when we were doing the procedure to get the blood cultures, or if it's something else. Echo to confirm a new murmur, and a chest x-ray to look for pulmonary emboli or other things that might be causing it, like pleural effusions, things like that. So in order to diagnose this, for definitive infective endocarditis, you have to have 2 major symptoms, or 1 major and 3 minor, or 5 minor. This drives students crazy, but it's something you got to know. The boards will ask this. This is going to be there. And then you got to separate it out from possible endocarditis, which is 1 major, 1 minor, and 3 minor. So you use these charts to pull this together. So the criteria, just like we just talked about, 2 major for clinical criteria, or 1 major, 3 minor, or 5 minor. That's what we're looking for. So then we got to decide whether they are major. So we'll go over the major first. So blood cultures, come back, it's positive. Okay, good. So 2 microorganisms consistent with typical microorganisms that confirm infective endocarditis from 2 separate blood cultures, right? 2 locations. That's what we got to find. So we could be staph, IV drug users, strep viridans, more common in native valves, or this Streptococcus glypticus, which was formerly called Strep bovis. And if you see this one, what do you think? If you see Streptococcus glypticus, which is also Strep bovis, GI malignancy, exactly. And then the Haysick organisms, which can be many things, community acquired. You can get them out of the mouth. That's the most common location to get these. And then you can also get enterococci from other locations. But bottom line is 2 different blood cultures confirming the organism. Okay, that's one major. The other major is, as we look at it, is persistent blood cultures, right? One of the following. For organisms that are typically causes of endocarditis, at least 2 blood cultures from the same drawn at that time that are 12 hours apart. So we confirm I got staph at 8 o'clock in the morning, 12 hours later, I got staph again. So then that confirms it. We're done. For organisms that are more common skin contaminants, then we got we're worried about epidermidis. Then we're worried about, we got to go a little deeper. And so we've got to then separate out with 3 or 4 blood cultures separated by the time. So we do this to separate them out. Okay. We want to make sure it's not a contaminant. That's the bottom line. Now, we're not going to go into this detail for the test. This is for your reference. I'm not going to get into you having to distinguish, was it for, Staph aureus? Do I need to get 3 samples or 2? That's not the point. The point is it positive or not? And is there at least 2 of them? That's what I want you to focus in on. This is just awareness for clinical awareness. Now, the one thing you do need to know is if you get one Coxiella burnetii, which causes Q fever, it's usually from large animals, farm animals, but it can also happen from cats. People don't like to hear that. I don't like cats, but cats can do this. There's plenty of causes of Q fever with cats. So definitely want to keep that in mind. One diagnosis with that can do it, but it's usually typically large farm animals that give it. Okay. I know some of you like farm animals. That's okay. Major criteria. That was a joke. Don't be mad at me. It's just a joke. You like farm animals. That was yes, you guys aren't paying attention. All right. Major criteria. Evidence of endocardial involvement. We want to look at for echo. So if we see vegetations, that's an indicator, right? A new abscess, that's an indicator. Or we see that the valve has removed, like you put a valve in and it's dehiscence, it ruptured, okay? And prosthetic valves so that prosthetic valve moved. You put an aortic valve and it moved. So new valve regurgitation is also an indicator. So that's a major criteria. So a new valve regurgitation confirmed on your echo, okay? So 2 major, which is blood culture, right? 2 separated times, or just 1 single with Coxiella burnetii. And then we're going to go over the minor criteria. So the minor criteria are you had a predisposition. So I'm an IV drug user, okay? Or I had some nidus that damaged my valve. I've got a prosthetic valve or a valve lesion. I've got a fever, low grade, 100.4 or greater, right? So these are important to remember in Celsius. So Celsius and your temperature, they typically will give you both on the boards, but you want to remember 38 degrees Celsius is a fever. Vascular phenomena can occur. Arterial can lead to these emboli. They can get septic pulmonary infarcts and mycotic aneurysms, which can be many causes of mycotic organisms that are out there. You're learning a lot of them, I'm sure, in ID. Intracranial hemorrhage, conjunctival hemorrhage in the eye, and then Janeway lesions are key. Now, the other thing they can get is glomerulonephritis. So how do you diagnose that? With hematuria. They can have proteinuria. So you want to look for that. You want to look for urine and blood, and blood and protein in the urine. And then Osler's nodes on the skin, which can be painful. Rot spots in the eye, which are hemorrhages. And then get a rheumatoid factor blood test that could suggest that they're elevated. So you see evidence, you get positive blood cultures, though, only 1. That would be a minor criteria. You need 2 for major. So that makes the difference unless it is. What's the one example where I can get 1 blood culture and I've got the diagnosis? Coxiella. Good. You're following along perfectly. All right. So these are the major. So the bottom line is major 2 blood cultures or a new murmur associated with valvular disease, something in this line, especially if it's just an abscess, okay? Gonna be there. Yeah, and then minor criteria is the things that are predisposing to it, you got it. So now you know the difference between major and minor. So you got to put those in your head and keep those there. So we get labs, we get the blood cultures, right? So that's what we're doing. So we're wanting to try to find whether or not we get there. We do it from a minimum. We want to go with between 2 and 3, depending on where it's at. And we ideally want to get the blood cultures before antibiotics. And I'll explain when we might not do that. There's one exception, and I'll discuss that in a minute. We do it from different sites. That's the idea. So the major criteria, just put it in your head: new valve regurgitation, abscess, vegetations, or, and how do you do it? With a transthoracic echo. That's going to be the non-invasive way to find those lesions. So any of these 3 should make you think, that's a new problem, okay? On that echo, a transesophageal is more sensitive in some cases for small vegetations. If you have prosthetic valves, it's mandatory that you do a TEE. If you've had previous abnormalities and previous endocarditis, you might need it. Or if you're an obese patient, where you've got this huge patient, you can't see into the, with the transthoracic can affect it. So then it requires us to go get the transesophageal echo. So these are the indicators for when we would do a TEE, okay? Now, the minor criteria are really associated with those IV drug user predisposition, low-grade fever, right? It can be high-grade, but it's 100.4 or greater. Vascular phenomena could be associated with emboli going to the brain or into lungs. And then all of the immunological criteria. What lab test would you order to help? There's 3 lab tests that you could order that might suggest immunological phenomena. What are those 3 lab tests that you could order? ESR, rheumatoid factor, good, and CRP. Yeah, ANA is another one that you could add. So actually, there's more than 3, but ESR, CRP all suggest that there's an immunological component to it, or inflammation, and then you can add the rheumatoid factor that will really confirm it. Okay, so rheumatoid factor is the most important one to get, and then microbiology evidence. We saw the chart for what organisms they are, and then any new onset regurgitant murmur suggested. Okay. Oh, I forgot to ask. Check on learning from yesterday. What I told you yesterday, what murmur is most likely associated with infective endocarditis? Which one? Most commonly associated with it. So you're most commonly going to be dealing with the mitral valve, right? And then when it gets really infected, unless it's an IV drug user, then it's going to be associated with what? Yeah, the IV drug user is going to be on the tricuspid valve, right? Good, you're on the right track. So now vascular phenomena, some subconjunctival hemorrhage can occur with these patients. When you see this, usually this goes away on its own within 2 weeks. It's no big deal. You leave it alone. And it's not a big deal, but it is a minor criteria. The other things that can be is painless petechiae, which are Janeway lesions. These are not painful, okay? And then when we look at the splinter hemorrhages, are very important to remind yourself of, okay? Keep those in mind. Now, minor criteria, yeah, they go away on their own. Yeah, they sure do. Pulmonary emboli, very important to remember that they can be very troubling, because not only are they embolus, but they're septic. And so they've got bacteria on it. They can mimic pneumonia and pleural effusions really bad. And you can see tricuspid regurg that's needed, that requires extensive replacement of that area. So it's important to remind yourself that when you see pulmonary emboli in the wrong setting, you're like, hey, this doesn't fit. There's not a nidus. It's not somebody that should be getting pulmonary emboli. Think about infective endocarditis. Remember that you can get a lot of lesions in the lungs, and they can cause a vascular phenomena, which is problematic. Okay, they can spread and be big issues within the lungs due to tricuspid valve disease, and typically it's due to staph. These are examples, other pictures, visual cues. These are the Roth spots. You're looking in the eye and you're like, yep, there it is. I got the hemorrhage in that spot. Roth spots can be associated with lots of things, but infective endocarditis should be one of them that comes to mind. Glomerulonephritis, typically seen with hematuria and proteinuria. and then a positive rheumatoid factor, as we talked about, should make you think, this patient is an infective endocarditis. These Roth spots are important because they're associated with the immunological phenomena that's associated with it. Okay, and then the other key components here with this is associated with painful nodules, which we've been over several times. You're going to definitely see those again, you can imagine. EKG is not, it's always the initial step. We always get it, right? It's always the first thing we do, but it may not be very, very helpful, but you could see blocks. Goes back to the question you guys asked earlier. Anything that causes the heart to swell can cause blocks, okay? So, and that can lead to more serious conditions. The chest x-ray can suggest pulmonary emboli or focal infiltrate. If we suspect it, if I want to confirm pulmonary emboli, what study do I order? Confirm. I want to confirm it. CTA. Yep, CTA all day long. D-dimer is a lab test. It doesn't confirm anything. It only suggests it. Confirmation is CTA. Yep. Good. So labs. You want to always get urine to check for proteinuria. Why? Glomerulonephritis. Hematuria, proteinuria. CBC, we want to check and see if we've got anemia. We want to see if we've got a left or right shift. And we want to look for acute phase reactant, CRP and ASR. And then a rheumatoid factor is very common, 50%. You're going to get all the labs. One of the things that you're going to get on this test is you're going to want to be able to make sure, going back to ClinLab, that you can separate out a left shift from a right shift. Because if it's a left shift, it suggests it's bacterial. If it's right, it's more likely going to be viral. And you need to know that when you're dealing with infective endocarditis. Okay, so your organisms, this is just a chart, reminds of all the different organisms that could cause it. There's a few that I want to mention to you. So your Haysick organisms, they're in the mouth due to usually periodontal disease and can take up to 7 days to grow. And then the indolent cases of Strep viridans, very common, right? We know that. And then Coxiella burnetii can be due to many things, to include large farm animals for Q fever, and it's typically seen in that, but can also include cats. And then come down onto the ones where you can also get Bartonelli species that's transmitted by a cat scratch. So Bartonelli can do it from a scratch, so you can get Q fever or Bartonelli, either one, from cats. Now you know why I'm thinking about cats are not your best friends. Then Chlamydia psittacia is from bird exposures. We actually had one of my instructors develop this from birds at Fort Sam Houston. Got Chlamydia psittacia. It's not due to a sexually transmitted disease. It's from a bird. It's the one time you can say, I got chlamydia, and it wasn't due to sexually transmitted. That was a joke too. And then Whipple disease, okay, can be associated with patients that have systemic arthralgias. One of the key things with this patient that gives it away is the CNS involvement. So when you see somebody with infective endocarditis and they also have CNS involvement, you better think Whipple's disease and the organisms that are associated with it. And those are the key ones you want to keep in mind. All right, so now we're going to formulate a plan to treat these. So we got to determine whether we're going to give antibiotics immediately or wait until the cultures. And we'll talk about when we do that. And we're going to talk about that you do need to consult cardiac surgery because you might need to replace the valve. And obviously, infectious disease and cardiology are going to be managing these patients inpatient. Okay, so do we give antibiotics or not? That's one thing we got to decide before we get the results. So stable patients, nah, we don't need to do that. We don't have to, we got time. So we admit them, get the blood cultures, come back in 1 to 3 days. We establish an accurate diagnosis, then we treat, okay? Unstable patients though, they're hypotensive, altered mental status, just like just like an MI patient, unstable, then we begin treatment after we got the cultures obtained. So we get the cultures, but we don't wait to get the results. So we draw the cultures and then we start the antibiotics. And the blood cultures are obtained from different sites. We space them out for 30 to 60 minutes, and then we start the antibiotics. So we do an antibiotic administration. Vancomycin is going to be the preferred drug is initially, and I'll talk about why in a minute. but you draw these blood cultures. So these are the two options. If they're stable, we wait until we get the blood cultures back and the sensitivity and specificity of that drug. If they're unstable, we wait until we draw the blood cultures and then give the antibiotics. Any questions? It's pretty straightforward, but just make sure you understand it. All right, antibiotics, we're looking for organisms. So if you're an IV drug user, we're thinking staph. And we want the minimal inhibitory concentration of penicillin to get to the kill organism. That's the MIC, that drug. And that could be penicillin or any antibiotic. That's what we're doing. Is it right or left side involvement? And where is there resistant organisms? Typically, these are the way that these patients' timelines work out. And you can notice that treatment lasts 4 to 6 weeks. So antibiotics need to be on for 4 to 6 weeks. Most patients start getting better at the 2-week mark, luckily, but they still need antibiotics for the 4 to 6 weeks. How long do they need antibiotics for? 4 to 6 weeks, 4 to 6 weeks, 4 to 6 weeks. If you choose anything else, you'll be very, very disappointed. Okay, empiric therapy, vancomycin is an appropriate initial therapy for these patients until we get their culture results back. Why? Because of methicillin resistance, and that's why. And there are many other options that we can consider, but right now, vancomycin is the preferred initial treatment that you're going to go to. You'll see that on your boards guaranteed. The other one that you'll want to determine is if you highly suspect it's strep, once the cultures come back, then we want to think about high dose penicillin, and it can be really difficult to treat. For staph, we want to think oxacillin susceptible. The big ones is nafcillin plus gentamicin. Here's a key point. You never, ever give gentamicin alone. Gentamicin never is alone by itself. It can be with other things, but never by itself. It's an additional drug, okay? So gentamicin, you can use cefazolin plus gentamicin, it doesn't matter, but you can never give it by itself. So it's just not effective by itself. It'll actually be very harmful, okay? So staph, you can use vancomycin, which we just talked about. If they're allergic to penicillin, ceftriaxone. This is a drug you want to know everything about. I love it. It's easy because you can use it in pregnant patients. You can use it in kidney failure because you can't use fluoroquinolones in kidney failure, but you can ceftriaxone. Ceftriaxone is good for lots of things, and we use it. It has minimal side effects. It's just a winner. But you have to combine it with gentamicin in these patients, okay? And or you can just usually single vancomycin. But if you're in doubt and you're just like, I don't know what antibiotic to go with, ceftriaxone is a good one to go with. Complications to be aware of are emboli, CHF, abscess formations that can occur. Because why? Because you got bacteria growing in there. Intracranial hemorrhage that can slide off. And then unfortunately, these can affect the kidneys. So the bacteria get to the kidneys and from an immunological response, not the actual bacteria itself, but the immunological components that are building from it cause the glomerulonephritis. But some bacteria also get to the kidney as it filters. Surgery is usually deferred until it's an emergency. But if you have refractory pulmonary edema, they need surgery. Severe regurg, they need surgery. If they're in cardiogenic shock, it's emergent. How do I know they're in cardiogenic shock? What vital sign would tell me this patient's in cardiogenic shock? What would they be? There's one key thing with it, right? They're what? Hypotensive, yeah, low blood pressure. That's the key. And then any degree of heart failure is considered urgent. This is a heart failure lecture. We're all about heart failure. So any degree, mild, moderate, severe, that's a great test question because it throws you off. You're like, mild heart failure. Nah, I don't think they need surgery, but they do. And so it's urgent. Doesn't mean you have to do it today, but it needs to be done quickly. And so urgent is in medicine is usually 72 hours. Emergent is right now. Between now and 4 hours needs to be done. Okay, so that's kind of how you think about emergent is 1 to 4 hours, urgent 3 days typically. It could be, and it's up to the provider, but usually that's where it's at. Abscess and fistulas, also urgent. usually 24 hours for those. So some of that's variable based on the disease. And then bacteremia, we want to start consider surgery that's not responsive to antibiotic therapy. Okay, so check on learning. What is the most frequent etiology of acute infective endocarditis and IV drug user? So this guy's an IV drug user. Which one of these is it? Is it Strep viridans? Is it Staph aureus? Is it Staph epidermidis? Or Strep bovis? Which one of these organisms is it? So this guy's an IV drug user. Okay, most of you guys got that. Awesome. So when you look at this, right, you're thinking Staph aureus. So along that line's exactly where you want to be. Strep viridans is for native valves. Staph epidermidis is due to prosthetic valves, typically, and Strep bovis is associated with cancer. Okay. Surgery, we already talked about the indications for those. Always remember that there are certain things in medicine that are always true. They'll be true today and twice on Sunday. If you see somebody with Pseudomonas, that is a very good indicator that this patient's really, really sick. They're usually diabetic, and they usually don't make it. So this is the worst case scenario, and they're not associated with antimicrobial therapy. Doesn't work real well for this, and they need surgery. So when you see Pseudomonas, it should be, boom, big lights going off. This is not good. And any patient with staph infections, if it's on the left side, very difficult to control, mitral regurg or aortic regurg, very common that these patients don't do well. So as we talked earlier, early consultation with a surgeon is key to this. We got to do that. And the prognosis of these patients usually is okay as long as we control the organisms. Remember that the mortality rate of this is dependent on where we're at, but check on learning. If I told you the patient had Pseudomonas aeruginosa, what's their prognosis? How's that looking? How's that looking out? Feeling pretty good about it? No, that's not good. They need surgery, and their mortality is high. So they're definitely going to be, you're never going to treat that outpatient ever. Probably not. Okay, so let's talk about the last part of this, which is infective endocarditis. We want to prevent it. So prophylaxis, you guys always get asked this question, so I'm going to bring it up. What we're trying to do is prevent. So we want to prevent infective endocarditis. How do we do this? Well, we give an antibiotic before a dental procedure or some procedure that's going to affect it. So that's the key with this, okay? So prophylaxis is only in a setting associated with high risk of somebody developing infective endocarditis. Who gets it? So those with prosthetic heart valves, including mechanical or bioprosthetic, grafts, so something surgically implanted, or material that to fix the rings or cords around the valves, a prior history of infective endocarditis. I mentioned that earlier. That would be somebody that would get prophylaxis for life because, hey, they've had a prior history. We want to prophylactically treat them. Unrepaired cyanotic heart lesions. So if you don't repair tetralogy of Fallot, you better give them an antibiotic before they have a procedure. Why are they at high risk? So these things that if you repair the congenital heart disease, then it can change their risk, okay? So after 6 months, you might be able to pull them away from that antibiotic and not give it to them in the future. So some repaired, if we do it through a catheter or a stent, that after 6 months, hey, we're done. We don't need to give them antibiotics anymore, depending on how it was repaired. Valve regurg, due to structural abnormalities that when we see with transplanted hearts, obviously that's a structural abnormality. That's a nidus. So a lot of this is really common sense, except for a couple. So these high-risk ones are easy for us to remind ourselves of. This is the chart that's coming. Who do we give dental procedures to? That's ones we just went over, those high-risk ones. Now, what we want to do is talk about who we don't give it to. This is the most common board question. Who do we give the antibiotic to? Okay, we don't give it. All right, we don't give it for bicuspid aortic valve alone. Okay, if they have aortic stenosis, we do. But if they just have a bicuspid aortic valve, we don't. acquired native aortic or mitral valve disease, including mitral valve prolapse with regurg. They don't get it unless there's an underlying reason. So that's a new one. And then hypertrophic cardiomyopathy with latent or resting obstruction. We don't use it. So these are the ones we do not give it for. And so you got to know which ones we don't give it to. Okay. They vary. Our guidelines vary based on, whether you're allergic to penicillin or not, but the majority get 2 grams of amoxicillin 30 minutes before the procedure, 30 minutes to an hour before. Okay. And post-procedure antibiotics after the procedure are not needed. Okay. That's the key. So 2 grams. What is meant by latent or resting obstruction? All it's saying is that all hypertrophic cardiomyopathy is associated with, an obstruction. So it's an outflow obstruction. So whether the obstructions, even if it's occurring when you're seeing the obstruction without activity, you don't need to do it. So that it's in that category. Just put HOCM in the category list with it in context of hypertrophic cardiomyopathy, and that latent or resting obstruction is discussion. We'll get into more detail in the cardiomyopathy when I give you actual visual pictures to walk yourself through it. Okay, and I'll explain that more. It's better with a picture, Lieutenant Pistoia. Now, the antibiotics, if you can't give penicillin, you have to know some other things. So if you're allergic to penicillin, you got to go down here. So you got to remember cephalexin, clindamycin, or azithromycin, clarithromycin. These are the alternatives to if you're allergic to penicillins orally. If the patient can't take oral medications, you've got to consider more extensive drugs. One of them that's cool is ceftriaxone. As I mentioned earlier, it's very easy to use. Clindamycin or Vanco. That's the high end if you need it, okay? So the bottom line on it, remember the ones that you don't give it to, everybody else you do give it to. All right, so we discussed, as you're looking at these, this is all about somebody who comes in with a new fever and a new onset murmur should make you think, infective endocarditis. We went through the Duke's criteria today and talked about who we give antibiotics to and who we don't. The one thing I owe Lieutenant Pistoia in the class is when I talk about hypertrophic cardiomyopathy, I'll show you the latent and resting obstruction. So you'll see that just as a terminology so you can put it in your head. All right, any questions? Any questions? All right, this afternoon, we're going to be on congestive heart failure. Whoop, whoop, whoop. I know you guys are studying infective endocarditis, but I would love for you to watch. There's a 10-minute osmosis video that goes over the heart failures that could put you in the right frame of mind to understand the components. You know it, Baxter. I always update it with some pictures and try to make it add some check on learnings. So but I already updated the slide deck for this afternoon. It doesn't change the core. You